Thank you very much, Dr. Page. It's a very kind introduction. It's a great pleasure to be here in Madison, Wisconsin. My only second time in Wisconsin. I'm really enjoying my trip. I'm going to be describing this relationship between heart disease and diabetes that has fascinated me for about 25 years. And I have done a version of this lecture probably for about 10 years, and it used to be called In Search of the Holy Grail. And I think what I'll try to do is convince you that over the past 2 to 3 years, we may have actually found at least a piece of the Grail that helps us improve cardiac function in our patients with type 2 diabetes. So these are my disclosures. I do a fair amount of consulting and clinical trials work with companies that are studying diabetes medications. And the way I've structured my comments is first to just briefly review what we know about glucose control in general. So this is just about hemoglobin A1C control, not about individual drugs, although admittedly it's really hard to extricate the drugs that we use to lower glucose from the glucose lowering itself. We'll look at the current landscape of glucose controlling medications that we're using for type 2 diabetes. This should be a brief review for most of you. And then we'll describe what we know about cardiovascular safety of diabetes drugs, and specifically the famous FDA guidance that went out to industry in December of 2008 that really changed the way we approach clinical trials in this space. We will then review the two major categories of drugs that have recently been shown to have cardiovascular benefits, surprisingly so, the SGLT2 inhibitors and the GLP-1 receptor agonists. Then I'll reflect back on the thiazolidinediones. These are an older class of medication. There's actually some new and exciting data about their role in protecting patients from atherosclerosis. And then we'll finish up on describing the impact of the data that I will describe to you on clinical guidelines. So this is a famous slide that comes to us from the UK PDS, which was a treatment trial looking at aggressive versus not so aggressive diabetes control in type 2 diabetes, published back in the 1990s. But this is an epidemiological analysis looking at the relationship of, in the overall trial, forgetting about the randomized groups, in the overall trial, the link between hemoglobin A1C over time and on the left, macrovascular disease, specifically myocardial infarction, and on the right, microvascular disease, specifically retinopathy. And you can see that there is a relationship, but it's much cleaner with microvascular disease. The higher your hemoglobin A1C, the greater your risk of developing retinopathy. And sure, there's a relationship here, but it's certainly not as pretty, if you will, as we saw with A1C and microvascular disease. And this actually translates this almost dichotomy in terms of the connection between glucose control and micro versus macrovascular disease. It translates to what we saw in clinical trials. So on this slide is probably about 30 years of diabetes clinical trials, type 1 with the DCCT and type 2 with the UK PDS, Accord, Advance, and VADT. And these trials attempted to control glucose more aggressively in the treatment group, and then the standard of care group would have less stringent control. And uniformly, each of these studies, whether it's type 1 or type 2, demonstrated a clear benefit on reducing microvascular disease. I know there's some endocrinologists in the audience, and this is what we do, right? We control glucose to prevent our patients from going blind, needing to see our nephrology colleagues, and from losing their toes from neuropathy. But when you look at the more prevalent complications of diabetes, cardiovascular disease, and certainly mortality, uniformly, there is a neutral effect with one exception that I'll address in just a couple of minutes. But in each of these, whether it's type 1 or type 2 diabetes, cardiovascular disease and specifically mortality, most of which is cardiovascular mortality, there is absolutely no benefit from tighter versus looser glucose control. In fact, in one study, and this is the exception, the Accord study, there was actually an increase in mortality, and most of this was cardiovascular mortality, in those patients that were randomized to more intensive therapy. So just reflect on that for a second. Here you have a widely prevalent disease, type 2 diabetes. Last time we checked, CDC, 29, 30 million patients with type 2 diabetes. And the major clinical manifestation of diabetes, last time I checked, was hyperglycemia, right? That's the major abnormality. And the major complication in terms of prevalence is cardiovascular disease. Our patients don't die from retinopathy or neuropathy necessarily, but they die from strokes and heart attacks, and lately heart failure. So fixing the most important metabolic abnormality in this disease does nothing to reduce the major complication of the disease. This concept has frustrated me and most diabetologists for decades, and we're not able to fully understand why that is. It gets more complicated, though, as many things do in medicine. In many of these trials, there was so-called follow-up investigation. So the trial is over, the randomization is over, and patients are either brought into the clinical center once a year or just telephoned once a year to say, have you had a heart attack in the last year? Are you alive or dead? And when you do those studies, even though after the randomized clinical trial is over and the hemoglobin A1Cs coalesce, right, because the aggressive control patients do a little worse and the patients who are not so aggressive tend to do a little bit better. When you follow those patients over time, you tend to see a small benefit on cardiovascular disease and in 2 studies on mortality. So how do we digest this information? I think that if you control glucose for 3 to 5 years, which is what most of these trials, how long they last, there's zero impact on cardiovascular endpoints. But if you invest the time early on, there may be this kind of almost an echoing effect in future years. Some of these follow-up trials go 20 years into the future. It's modest. There may be a 15% relative risk reduction, and it pales in comparison to the more prominent risk reductions that we see, 30, 40, 60, 70% on microvascular endpoints. Now, why might this be? Well, it could be simply a reflection of the complexity of macrovasculopathy, right? It's not just about glucose. If you go into your coronary care unit now, I bet you it'll be a third, a third, and a third. A third of your patients will have diabetes. A third of your patients will have prediabetes. And the other third, most of them will have some form of metabolic syndrome. So there's a lot of dysmetabolism, but not all those patients are substantially hyperglycemic. So there are other risk factors, right, for cardiovascular disease, lipid abnormalities, obesity, hypertension, et cetera, et cetera, et cetera. For microvascular complications, it's pretty much a diabetic complication, right? You don't see diabetic retinopathy in patients without diabetes. So glucose is a much more important piece of that smaller puzzle. And that's how I look at this. So what about the current landscape of how we lower glucose in type 2 diabetes? For type 1 diabetes, I think it's a simple pathophysiology. And we don't understand the nature of the immune defects that lead to type 1 diabetes. But clearly there's autoimmune destruction of beta cells. If you don't have beta cells, you don't have insulin. If you don't have insulin, you are hyperglycemic. So the pathophysiology of hyperglycemia in type 1 diabetes is relatively straightforward. Now contrast that to what we know of the pathophysiology of type 2 diabetes. It's much more complex. There's clearly a pancreatic defect, but it's more modest than in type 1 diabetes for sure. Most of the early abnormalities are here, down on the right side of the slide, which is a designation of the concept known as insulin resistance, which means simply that the muscle and the fat, these are the major sinks for glucose in the postprandial phase, need more insulin to get glucose inside the cells. And the pancreas is typically able to respond for many years by producing large amounts of insulin, so patients are hyperinsulinemic, yet they maintain normal glucose tolerance. And in those patients that have faltering of their pancreas over time develop hyperglycemia, when the demands of the body are no longer met by the endocrine pancreas. The liver is also involved by increasing glucose production, which is also under the regulation of insulin. There are glucagon defects. Glucagon secretion is enhanced in patients with type 2 diabetes. Some of that may be modulated by the Incretin system, which is this neuroendocrine communication between the GI tract and the pancreas. We found out more recently that there are probably renal defects that lead to type 2 diabetes in terms of not being able to excrete as much glucose as the kidney should. And much of this is probably under the dysregulation of the brain, but really at a very early stage in understanding that. So clearly, type 2 diabetes is much more complex than type 1 diabetes. And this explains why there's so many drugs to treat type 2 diabetes. That if you're the CEO of Merck or Pfizer, you're going to set your scientists on one of these pathophysiological abnormalities to try to fix that defect. And clearly, because type 2 diabetes is so complex, many of our patients require more and more therapies as their disease gets worse over time. To simplify, these are the 7 major drug categories that we're using to manage type 2 diabetes. Insulin, sulfonylureas, metformin, thiazolidinediones, and this is a bit of an alphabet soup now, but you have the GLP-1 receptor agonists and the DPP-4 inhibitors that address the incretin defects, and then the most recent drug class, the SGLT2 inhibitors that increase glucosuria, which is an odd mechanism of action, admittedly, but this is actually one of the drug classes that has been demonstrated to have not only cardiovascular but also renal benefits. So there's a lot of interest in this drug class. How clinicians are supposed to put this cacophony of diabetes drugs together in a logical formulation for individual patients is described on the so-called algorithm from the American Diabetes Association and the European Association for the Study of Diabetes. We're supposed to start with healthy eating and weight control, increased physical activity, and diabetes education, and most patients will require metformin as foundation therapy. So this is drug number 1 in virtually all patients. And then beyond that, until recently, the ADA and the EASD said you can do essentially whatever you want. I mean, if your goal is to reduce hemoglobin A1C, then after metformin, if patients are not getting adequate control, you should add one of the following 6 other major drug categories. If you're a traditionalist, you can use a sulfonylurea, just watch out for hypoglycemia. If you think your patient is very insulin resistant, and 85% of patients with diabetes are insulin resistant, and you don't mind the adverse effects of TZD, such as weight gain and edema and heart failure risk, you can use a TZD. If your patient is complicated or older, or maybe has some CKD or has lots of side effects to everything you've ever prescribed to them, then you go with a DPP-4 inhibitor. It's a relatively weak glucose-lowering agent, but a paucity of side effects. If patients want to lose weight, then you move to a GLP-1 receptor agonist as long as they don't mind injecting. If the patient is way high from their hemoglobin A1C target, you might just start with basal insulin on top of metformin. And the role of the SGLT2 inhibitors was not quite clarified at that point. It was a new drug. It appeared to be reasonably safe. There were some benefits, there were some risks, but the group thought that at that point it deserved a seat at the table in terms of being a reasonable second-line strategy after metformin. Most patients will get 3 to 6 years of control with each drug, but as patients age, they often need additional therapies, as sometimes happens with hypertension as well. So dual therapy would move to triple therapy, and then ultimately to combination injectable therapy, either basal insulin and mealtime insulin, as you might use with a very insulin-deficient type 1 diabetes patient, or basal insulin plus a GLP-1 receptor agonist. So this was the standard approach since about 2012, when we put this algorithm together. It was okay. I mean, it gave you nice colors, it gave you some choices, but it really didn't help, particularly the primary care physician, in terms of choosing which drug. It really was a kind of a discussion between the patient and the physician, trying to figure out which was the best strategy for that individual. And I'll reflect back on this at the end, because the guidelines are changing, and we now have evidence-based medicine approaches to managing type 2 diabetes. So this all started with this notion of cardiovascular safety of diabetes drugs and the FDA guidance. And here I've listed for the 7 major drug categories before clinical trials. This is just looking at, in preclinical studies, the potential cardiovascular pluses and minuses of each of these drugs. Let me just give you one example. The GLP-1 receptor agonist, relatively new, injectables, some weight loss, blood pressure reduction. There may be some cardiac effects directly, at least in animal models, but they increase heart rate. And most cardiologists will tell you that anything that increases heart rate is probably not a drug that you're going to look to decrease cardiovascular events. I'll give you another example. The TZD is a very controversial drug class. Lots of benefits, such as reducing hyperinsulinemia, beneficial effects on lipids, prominent effects on lowering CRP, which is supposedly good for the cardiovascular system, but increases sodium retention and can precipitate heart failure. So, where's the net in these drugs in a patient population who is at very high risk of cardiovascular disease? Well, obviously you need clinical trials to figure out where these risk factor modulations actually pan out. And this really became extremely serious in 2007 when a drug, rosiglitazone, which was a TZD, that again was supposed to have lots of benefits, was suspected of actually increasing cardiovascular ischemic events. So this was a famous, somewhat controversial meta-analysis that was published in that year that suggested that here was a drug that was increasing in popularity, being used in millions of patients across the globe, that could actually not just lower glucose, but also increase cardiac disease. So the FDA just changed their policy and they said, listen, if this is to industry now, if you are going to bring a new drug to market beyond metformin and sulfonylureas and those TZDs, you have to at least demonstrate safety. We're not asking for much. We're not asking for demonstration of efficacy. Just show us that your drug is not going to kill people so that we don't have to go through this nonsense 5 years from now. That's basically what the statement said. So what they recommended is that there be a pre-marketing analysis so that the cardiovascular events were hopefully resulting in a hazard ratio of about 1.0 or less, but importantly, the upper bound of the hazard limit, the confidence interval, was less than 1.8. So be sure that there's no way that your drug increases cardiovascular events by more than 80%, is what this slide says. But after post-marketing analysis, you're supposed to shrink that upper bound down to 1.3, so no more than a 30%. But in all seriousness, you have to have a hazard ratio of around 1.0 or less to get that upper bound less than 1.3. You can never have an upper bound of the confidence interval of 1.0, right? Or you'd need to study an infinite number of patients. So there's always a little bit of uncertainty in these clinical trials. Suffice to say that this meant that large cardiovascular outcome trials had to be conducted to get new drugs to market. And this is why you're seeing that patients, perhaps here at University of Wisconsin, are involved in these large clinical trials demonstrating cardiovascular safety of glucose-lowering medications. I think at one point, 2 years ago, there were some 300,000 patients involved in these trials throughout the world. So what do we know about cardiovascular outcomes and diabetes medications before the guidance? Well, this is a little bit different than what I've showed you before. This is studies looking at individual drugs, not glucose lowering itself, but individual drugs and their impact on cardiovascular disease. And again, most of these have been neutral. Certainly insulin and sulfonylureas, and rosiglitazone was ultimately vindicated in my mind with a large clinical trial showed neutrality. No benefit, but neutrality. Metformin, I gave it a green arrow down because there are some really small trials suggesting that metformin may have a cardiovascular benefit. It's what we teach. Diabetologists in the audience know that we teach students and trainees that metformin has a cardiovascular benefit. If you actually look at the database that statement is based on, it's tiny. I mean, there are more events, cardiovascular events, in modern large clinical trials than there were patients in the metformin trials. Just think about that. And I gave pioglitazone a down arrow here because there was a study known as the PROACTIVE study back in 2005 that suggested that there was a reduction in MACE, major adverse cardiovascular events, but that was a very controversial study that I'm not going to get into because there were controversies in terms of methods, and it was not viewed as a pristine study. So there was some equipoise about the role of pioglitazone in cardiovascular disease. And then the three drugs that were unlucky to be introduced into the market right after the FDA guidance had to come up with these large CVOTs. And while I was a critic of these, thinking that these were unnecessary, they were expensive, if there was no preclinical signal of risk, you'll see that we're now garnering the benefits of having done these clinical trials because there were some surprising cardiovascular benefits from at least two of these drug classes. So FDA guidance before and after, and we'll talk about the clinical trials that have come post-guidance. So this was the landscape of cardiovascular outcome trials. It has its own acronym, CVOTs. And again, lots of patients in these trials, most somewhere between 5 and up to 14 or 15,000 patients, again, to try to demonstrate safety so that you get that upper bound of the confidence interval under 1.3 eventually. There were 5 DPP-4 inhibitor trials, 6 GLP-1 receptor agonist trials, and 4 or 5 SGLT2 inhibitor trials. I'm not going to review the DPP-4 inhibitor trials because they're very boring. They're completely neutral, as you might expect, based on the fact that glucose control itself doesn't do it. Most of the other drugs haven't done it, and these are trials of about 2 to 3 years. So what hope would you have of a drug given to a patient, the lowers hemoglobin A1C, maybe 0.5 or 0.6 percentage points? What hope would you have of that drug impacting stroke, MI, long-term atherosclerosis? Suffice to say, there was no hope, right? These were neutral studies. I put neutral in quotes for SAVOR, which is saxagliptin, because there was a surprising negative with saxagliptin, which was a 27% increase in heart failure hospitalization. No idea why that occurred. It wasn't seen with the other 2 DPP-4 inhibitors. But at least for MACE, which is the primary outcome in these trials, major adverse cardiovascular events, there appeared to be zero benefit. But importantly, according to the FDA, which is what they wanted, zero risk. The hazard ratios were about as close to 1.00 as you can get. Now, let's move to the SGLT2 inhibitors, because now it actually starts to get more exciting. I mean, diabetologists were nearly suicidal at the revealing of the DPP-4 inhibitor trials, because we had anxiously anticipated that one of these trials is going to be positive. And in fact, 3 out of 3 were absolutely negative. So there was actually no hope that even the SGLT2 inhibitors, which are also very short trials, were going to have a cardiovascular benefit. Just to review, this is a transporter that is situated on the tubular luminal side of the proximal nephron that serves to resorb glucose as well as sodium, which is, I think, is important when we look at some of the heart failure outcomes, and gets glucose out of the urine and back into the plasma where it belongs. So SGLT2 is situated in the proximal convoluted tubule, and it is responsible for 90% of the reclamation of glucose from the glomerular filtrate. SGLT1 is mainly expressed in the intestine and is only responsible for about 10% of the reabsorption. So in most circumstances, unless the glucose threshold is exceeded, which is 180 milligrams per deciliter, there will be minimal glucose excretion. If you exceed 180 milligrams per deciliter in the glomerular filtrate, you'll start spilling glucose. But if you now pharmacologically inhibit SGLT2, you will actually develop glucosuria. And the loss is on the order of about 300 kilocalories per day, if you do the math in terms of how much glucose you could lose. And unfortunately, that does not lead to dramatic weight loss. You'd think that if you do the math, you'd lose about a pound every 10 days, right? Patients would disappear after 6 years. But there are other mechanisms in place that prevent that. Most patients lose about 2 kilograms, which is not bad. This is the renal threshold in the normal kidney. Interestingly, as I alluded to before, in type 2 diabetes, there may be an increase in that threshold. So one could say that the diabetic kidney doesn't get rid of enough glucose as it should. But basically, you reduce that down to at least 70. Some studies show that you reduce the threshold down to 40. Yet patients do not get hypoglycemic because the body has other mechanisms such as curtailing of insulin secretion to prevent hypoglycemia. So it's an interesting mechanism of action, a little bizarre, right? Last 30 or 40 years, we've been trying to control glucose and prevent glucosuria, but this actually activates glucose excretion in order to lower plasma glucose. How well does it work? It's all right. I mean, it's about an A1C reduction of about 0.7, maybe 0.8, not much stronger than the DPP-4 inhibitors, which are relatively weak agents. You do get this 2 kilogram loss of weight. You do get a little bit of drop in systolic and diastolic blood pressure, about 4/2. So it seems to be beneficial. And if you analyze the risks, benefits, and you can construct this type of diagram for any of the drugs that we use in any field in medicine, not just diabetes. You know, there are pluses, there are minuses. So before the CVOTs, the cardiovascular outcome trials, came out, there were some benefits. You know, you got glucose reduction, very low risk of hypoglycemia, some of the other benefits, but there were some risks. Patients urinate a lot, and this is not a great thing for an aging guy with BPH, right? You convert them from 2 times nocturia to 3 times nocturia. They're not sleeping and they're not happy. It can increase the risk of genital mycotic infections, more so in women than in men, but men can get candida balanitis as women can get candida vaginitis because of the mechanism of action, right? There's more glucose in the urine. Some studies have shown an increase in UTIs. GFR goes down a little bit, but interestingly, it seems to be protective for the kidney long term. There's this interesting risk of diabetic ketoacidosis that was initially revealed when the drug started being used off-label in type 1 diabetes, which I'm not recommending. About 10% of patients with type 1, if it works to lower glucose, glucose will come out of the type 1 diabetic kidney just like the type 2 diabetic kidney. But it can induce a diabetic ketoacidosis in some patients. It's complicated as to why. I don't think we fully understand it, but it's a major risk for off-label use, which we're not recommending. And some studies have shown an increase in fracture rates. And then came EMPA-REG outcome. So this was the first large cardiovascular outcome trial with positive results, not just safety, but actually reduction in cardiovascular endpoints. 7,000 patients randomized to 2 doses of empagliflozin and placebo. Primary outcome was 3-point MACE, which is MI, stroke, and cardiovascular death. This was added to background therapy, so patients would have their other diabetes medications adjusted to achieve local standard A1C target. Importantly, all these patients had not only type 2 diabetes, but also cardiovascular disease. So whatever we learn from EMPA-REG, you cannot cut and paste or extrapolate to the more common patient that does not have cardiovascular disease. I think that's important. This was the main outcome, which was 3-point MACE, and the reduction was 14%. Which is all right. I mean, doesn't bowl you over. It's kind of in the same range as I talked about with long-term glucose control. But I would remind you, this is the first time that any benefit has been demonstrated in a long-term cardiovascular outcome trial with a diabetes glucose-lowering medication in patients at high cardiovascular risk. Now, what was more impressive was the component that drove the MACE reduction. Remember, it's MI, stroke, and cardiovascular death. If you talk to most patients, the most important one would be cardiovascular death. And here there was a huge 38% reduction in cardiovascular mortality. Interestingly, all-cause mortality was also significantly reduced by 32%. Never before ever seen in a diabetes trial. DCCT, UKPDS, no impact on mortality. Interestingly, there was this early divergence of the event curve. So those of you that are used to seeing these Kaplan-Meier curves from atherosclerosis-type trials, like blood pressure meds or lipid-lowering drugs, know that the curves start to diverge somewhere around 12 to maybe 18 months. So something is going on very early that is still not quite understood. But there's an early effect to reduce cardiovascular death. And the other components were not significant. So MI went in the right direction, but it was NS, and stroke, interesting, went in the wrong direction, but was also not significant. So this does not have the thumbprint of an atherosclerosis type of mechanism, does it, right? And usually with atherosclerosis, at least you get unanimity in terms of the directionality of the movement of the point estimate in terms of the individual components. And the other, this is a secondary outcome, was hospitalization for heart failure. Actually, heart failure is an epidemic in type 2 diabetes, at least in the US. The most common reason for hospitalization in patients with type 2 diabetes nowadays is heart failure. So reducing, and remember, the TZDs actually increase heart failure. Even pioglitazone, that has some beneficial cardiovascular effects, clearly increases heart failure risk. So this is definitely on the radar screen of our cardiology colleagues. Again, prominent 35% risk reduction and a very early divergence of the event curves as well. It seemed to be helpful in both patients with and without heart failure. So you could even push the envelope and say it does not only prevent the deterioration of those patients with established heart failure, but may also prevent new heart failure from developing. And when we stratified patients in the study who were at low, medium, or very high risk for heart failure hospitalization, there appeared to be consistency in terms of the risk reductions. The second trial, which was just announced about almost a year ago at the American Diabetes Association meeting, was the CANVAS program, which looked at a second SGLT2 inhibitor, Canagliflozin. And here, interestingly, and this is, you rarely see this in clinical trials, but the risk reduction for MACE was identical to EMPA-REG. Point estimate of 0.86, so a 14% risk reduction. So I think that kind of buttressed the findings of the original trial. Here, however, there was actually more consistency in terms of the components. Cardiovascular death, MI, and stroke were all to the left side of unity, but none were statistically significant. Yet there was this almost identical. Remember, with EMPA-REG, it was 0.35. Here was 0.33. I'm sorry, 0.65, 35% risk reduction, 0.67, 33% risk reduction for hospitalization for heart failure. One of the negatives in the CANVAS trial was this increase in amputations, which was a twofold increase in mostly toes, but we talk to patients, toes are important. And the reason for this is not exactly clear. We went back into EMPA-REG's data. We were not looking at amputations prospectively, but we were able to go back and collect the data. And here we did not see any signal of an increase in risk of amputation. So why this might be, not quite clear. If this is simply, did we get lucky? Did they get unlucky? We're just not clear. We need to look at more data from other clinical trials. You know, when we set up the EMPA-REG trial, we had this review article that we published about a year before we saw the data. And here we were mainly ruminating about, you know, what if EMPA-REG were positive? What might be the mechanisms of action to reduce cardiovascular disease? And we were completely wrong, right? We were singularly focused on atherosclerosis, right? Because we know that there's accelerated athero in patients with diabetes. So we talked about, you know, blood pressure and insulin levels and body weight, and we had it all wrong because, as I showed you, those event curve separations were so early, cannot possibly be an effect on atherosclerosis. So there are 4 new theories as to what the effect of the SGLT2 inhibitors might be, particularly on cardiovascular mortality. Some have proposed that this is related to simply being a diuretic. Now, cardiologists would scoff at that because they tell me that diuretics don't necessarily alter mortality, even in patients with heart failure, but it has diuretic or natriuretic properties. Some have proposed that slight increase in beta-hydroxybutyrate that can precipitate DKA is actually beneficial. There are some vascular biologists who feel that ketones are a more efficient fuel source for the heart, which is an interesting concept. Others have proposed that there are direct cardiac effects through the sodium-hydrogen exchanger. and some have felt that this is all related to the benefits of the SGLT2 inhibitors on the kidney. Suffice to say that we have no clue as to what was going on, at least in the EMPA-REG outcome trial. This was an initial attempt at trying to figure out what might be driving the cardiovascular mortality benefit. So here we controlled for each of the individual covariates that we had access to in the trial. What we measured, you're condemned to what you measured in these trials. And the point is to move this hazard ratio toward 1.0 by controlling each individual. So, for instance, in the DCCT trial that I showed you, type 1 tight control versus loose control, if you do this so-called mediation analysis, this is statistical, so with all the caveats of statistics, if you do this mediation analysis for hemoglobin A1C, you obliterate about 95% of the treatment effect for retinopathy, suggesting that control of A1C is important for the protection against retinopathy. So here we're controlling for each covariate individually to see which covariate moves the needle, if you will, toward 1.0. And you can see that nothing moved. When you controlled for A1C, it's not driven by A1C. Even blood pressure and body weight. The only thing that moved the point estimate toward 1 was actually the change in hematocrit. So this is about 50% of the benefit can be explained by the change in hematocrit. And what hematocrit does with SGLT2 inhibitors, it goes up about 3 to 4 percentage points. We feel that's related to a contraction of plasma volume. Others say that it's an increase in hematopoiesis, but it's hard to imagine how that might affect cardiovascular mortality. So we think that this is a reflection of the diuretic effect of the medication, that this is a diuretic that has a sustained effect on plasma volume, doesn't activate other neurohumoral compensations for reductions in plasma volume. Renin doesn't go up, catecholamines don't go up, and we think that if you reduce the plasma a little bit in these patients at risk for heart failure, you prevent them from dying. I know that's a controversial statement, but this is what the data points us. But we don't know for sure because we don't have all the data that we wish we did, because we didn't think the study was going to be positive. So we didn't check NT-proBNP and all the things you might if you had a heart failure benefit. The GLP-1 receptor agonist is a second class that has a cardiovascular benefit, and this is the Enteroinsular Axis. These are two peptides, GLP-1 and GIP, that stimulate in response to meal ingestion are stimulatory signals from the small intestines to the endocrine pancreas. And this leads to an increase in insulin, a turbocharge, if you will, for insulin secretion, and reduction in glucagon, which affects hepatic glucose production. These incretin hormones are destroyed by DPP-4, an enzyme that results in these inactive incretin fragments, and the DPP-4 inhibitors are basically drugs that impede that enzyme that lead to an accumulation of endogenous insulin. And the second approach has been to create these agonists for the GLP-1 receptors that are resistant to DPP-4. So these are injectable, these are orals, these are much more potent than the DPP-4 inhibitors. And some have proposed that in addition to the four major activities, which is increasing insulin, decreasing glucagon, slowing of gastric emptying, and a decrease in appetite, which is why they lead to weight loss, there may be some other benefits, particularly in the cardiovascular system, because GLP-1 receptors have been found actually in the heart. So there's this hope that either through glucose reduction or other effects on cardiovascular risk factors or direct effects on the heart, that these drugs might be the holy grail to reduce cardiovascular disease. They are more potent than the SGLT2s and the DPP-4s inhibitors in terms of A1C reductions, about 1 to 1.5%, and they lead to more weight loss, somewhere between 2 and up to 3 or even 4 kilograms. The strongest GLP-1 receptor agonist may be semaglutide, which was just released, and this has consistent lowering of A1C almost above 1.5%, and reductions in body weight of almost 6 kilograms. And this is the liraglutide study, known as LEADER, that showed, again, you're getting this very consistent effect on MACE of about 13% here. And in terms of the components of 3-point MACE, again, consistency between the 3 major components and statistically significant reductions in cardiovascular death of about 22%. No significant effect on heart failure, however. And then finally, the most recent CVOT with GLP-1 receptor agonists is SUSTAIN 6 with semaglutide. And here you have a 26% reduction in MACE, which is larger than the other 2 studies. And again, consistent effects on MI and stroke, a somewhat large reduction in stroke for some reason. But interestingly, no effect on cardiovascular death. So there's some lability. The more studies you do, you realize that there's some lability in the point estimates for the individual components of MACE. So neutral DPP-4 inhibitor trials. I didn't tell you about a single neutral study that preceded LEADER in SUSTAIN 6 with lixisenatide that showed no effect. Beneficial effects with LEADER in SUSTAIN 6, and a fourth almost missed, or just missed, I should say, exenatide long-acting. I think the hazard ratio was 0.90, but was not statistically significant. So 2 positive and 2 negative trials in GLP-1, and again, 2 positive trials with SGLT2 inhibitors. What's coming is this Carolina study, which will be hopefully announced next year, which is interesting because it is a DPP-4 inhibitor trial, which have been reasonably unimpressive to date. But here, linagliptin is being compared to glimepiride. And those of you that have followed this field know that there have been suspicions of sulfonylureas actually increasing cardiovascular events. So because linagliptin is being compared directly to a sulfonylurea, this DPP-4 inhibitor may actually show a cardiovascular benefit, not because it results in a benefit, but because sulfonylureas may potentially result in a risk. So I think we'll finally have an answer to that 30-year question about the sulfonylureas. And then 2 other SGLT2 inhibitor trials. DECLARE will be announced later this year at the American Heart Association, I understand. This is the largest SGLT2 inhibitor trial with dapagliflozin. So we'll, again, look for the effect on cardiovascular death. Is EMPA closer to the truth, or is CANA closer to the truth? And then this issue of the amputations will be very interesting to look at, if this is truly a class effect or is individual to a specific drug in this class. What about the TZDs? These have been out since the mid-1990s, and there is some new data here. The TZDs activate a nuclear hormone receptor that alters gene transcription that favors glucose reduction, reduction in insulin resistance, and potentially anti-atherogenicity. This is the IRIS trial that we conducted that was concluded 2 years ago, insulin resistance intervention after stroke. We randomized almost 4,000 patients to placebo or pioglitazone, and the eligibility criteria were TIA or stroke, and not diabetes, but insulin resistance. So we felt that pioglitazone had a potent anti-atherosclerotic effect that was not mediated through glucose reduction, it's a recurring theme, but through its effect on insulin resistance. And our endpoint was fatal and non-fatal MI or stroke, which is essentially MACE. As you might imagine, if you recruit patients with insulin resistance, you're going to get a lot of patients with prediabetes. But the diabetic patients were excluded from the trial. And what we showed was a 24% risk reduction in MACE, essentially, in these stroke patients with insulin resistance. When we look specifically at ACS, we got a consistent 29% risk reduction. And this is the new international definition for stroke alone, was down 25%. So a consistent effect on these atherosclerosis endpoints. And actually, pioglitazone fares pretty well with other standard therapies for stroke patients, such as aspirin and lipid-lowering drugs, statins, and even the ARBs. Something in the same range as what you'd see here. And we also looked at the development of diabetes. So this also has a diabetes prevention effect, which is very strong, of about 50% risk reduction. So what about the impact of all these new data on guidelines? You remember the prevailing consensus statement from ADA and the EASD, where the paradigm was metformin and then, figure it out, do whatever you want, without any reflection on cardiovascular risk and impact of these therapies on cardiovascular events going forward. So as of January of this year, in 2018, this is kind of a tweak of the consensus statement. This is a yearly revision of the consensus statement that comes out based on new data. And it's very similar in terms of starting with monotherapy and then dual therapy, triple therapy, et cetera. But for the first time, there's a decision node in the guidelines, and it is cut and paste reflection of what we saw from these clinical trials. Not so much the TZDs or pioglitazone, because again, ours was a non-diabetes trial. So I think it's an interesting trial, but it can't possibly affect guidelines for patients with diabetes. I actually think it should, but the ADA does not agree. But SGLT2 inhibitors and GLP-1 receptor agonists for sure. So the node is, does your patient have cardiovascular disease? Simple question. Do they have an MI? Do they have a cabbage scar on their chest? Have they had a stroke? Do they have just peripheral vascular disease? Do they have CVD? And if the answer is yes, then according to the guidelines, you should be, after metformin, which is another controversy as to whether these drugs should be moved ahead of metformin, but to date, it's just after metformin, you should use an SGLT2 or GLP-1 receptor agonist with the caveat that you should choose a drug that's been shown to demonstrate or has been shown to have cardiovascular benefits. And if the answer is no, so no cardiovascular disease, then you go back to the 2015 statement and you do whatever you want based on. It's not wrong to use the SGLT2s or GLP-1s. They're extremely expensive. I'm not sure you're getting good bang for your buck at this stage. Most patients are going to be in this lower category. They don't yet have cardiovascular disease. So let me conclude. Correcting the major metabolic abnormality in diabetes, which is hyperglycemia, has had very little effect on its major complication, which is cardiovascular disease. Until recently, individual therapies that are used as glucose-lowering agents, despite some of them having pretty prominent effects on cardiovascular risk factors, such as lipids and some on blood pressure, have not had any definitive benefit on cardiovascular disease. Metformin, maybe, but in very few patients. Given all the controversies in the mid-2000s about diabetes therapies and their safety on cardiovascular disease, the FDA mandated that these CVOTs be conducted to demonstrate at least safety. And the first series of these outcome trials were neutral, mainly studying the drug that was just being released at that time, which were the DPP-4 inhibitors. They were safe, but they didn't have any effects on reducing cardiovascular complications. Since then, however, beginning in 2015, the SGLT2 inhibitor empagliflozin reduced MACE, CV death, and heart failure hospitalization in patients with type 2 diabetes plus cardiovascular disease. Canagliflozin had similar effects on MACE and heart failure, but not on CV death, and also with this question of amputation risk. 2 GLP-1 receptor agonists, liraglutide and semaglutide, also reduced MACE, but with different results on the individual components of MACE. And the TZD pioglitazone may be poised for rejuvenation. It's a generic drug now. It's probably 50 times less expensive than the GLP-1s or the SGLT2 inhibitors. The IRIS trial confirmed a cardiovascular atherosclerotic benefit, at least in this population of patients that we studied, which were insulin-resistant stroke patients. And these positive trials, specifically the SGLT2 and the GLP-1 trials, over the past couple of years, are starting to affect clinical care, and we're starting to see them reflected in type 2 diabetes guidelines. So with that, I'll thank you for your attention. I'd be happy to entertain any questions.
Thank you very much, Dr. Inzucchi. I'll ask you to call on the audience, and if you don't mind repeating the questions.
Sure. Please.
I've had several patients this year who I started on liraglutide because I'm hoping for the cardiovascular benefit, and then their insurance company tells me that exenatide is on their formulary. Do you feel like we have enough data at this point to be saying we should be pushing for liraglutide because it's got the cardiovascular benefit demonstrated? Things like that.
Yeah, so the whole issue of class effect. I think we have to. I mean, I know it's a big hassle, right, in clinical practice to get these 8, requests for prior authorizations, but I think we have to. We struggle with this in my state with the flozins, with the SGLT2 inhibitors, where dapagliflozin or canagliflozin, not empagliflozin. So I think we should push back a little bit saying, hey, if we're trying to practice evidence-based medicine, we should go with the drug. Now, leave yourself open because DECLARE may come out. And with exenatide LAR, if you look at the data, they came so close. I mean, if they had one more event, I think they would have had significance. So I don't think we want to be unreasonable, but I think our obligation to our patients is to go with the best evidence of therapy. Please.
What about the genome of your patients in these massive studies? Is there a breakdown of that, particularly Pima Indians, Hispanics in South Texas have a higher incidence of diabetes? Are they being evaluated a little differently? So
you're asking if there's heterogeneity of the effect of these drugs based on the genetic makeup of the patients. Obviously, a fascinating question. So I'll just answer very briefly. Number one, when we've looked at individual subgroups, at least in the EMPA-REG trial that I was involved with, we don't see any heterogeneity of effect. So it affects African Americans as Caucasians and Hispanics, et cetera. There does not seem to be a specific subgroup that benefits more or less, at least statistically, when you're comparing for an interaction. Unfortunately, we did not save samples in this trial. We thought it was going to be a negative trial, so you try to reduce the cost. So we didn't have any genomic data to go back. I know other studies do, so DECLARE is largest, 17,000. I know they're saving specimens, so hopefully we'll have some answers to that question. But at least at a 35,000-foot view in terms of phenotypes, racial phenotypes, there does not seem to be heterogeneity. Thank you. In the back? I was wondering if dementia is a variable that's been looked at in any studies. Well, we looked at cognitive function in IRIS, and that's mainly because we were working with a bunch of neurologists who were recruiting these patients with stroke, who obviously are interested in cognitive capacity. We could not actually distinguish a benefit in these, even though we reduced stroke, we could not actually distinguish an effect on dementia or cognitive performance. But it may be that the tool that we used was pretty crude, and maybe it wasn't the right tool to use in that population. But I'm not aware of any other. I'm sorry. I just learned yesterday that in the Carmelina study, which is the long-term linagliptin trial, they're actually looking at cognitive performance over time.
Before you take the next question, when you refer to a negative trial, what was the actual endpoint of the trial you're discussing? Was it a non-inferiority trial, and you happened to find a difference that was not the primary endpoint, which was a benefit? Or was it comparing the...
So you're talking about the cardiovascular, not the dementia question. You're talking about...
Just when you refer to a negative trial, you anticipated no difference.
Yeah, so you could say it's a positive trial, right.
A positive trial demonstrating non-inferiority. Is that
That's right.
how the trial was set?
That's right.
So it was not actually designed to demonstrate superiority except as a secondary endpoint?
No, there's a statistical method where you, and it's a hierarchical statistical method where you check for non-inferiority first. If there is inferiority, you wouldn't move to the phase 2. And then after you've satisfied the non-inferiority limits, then you move to superiority. Right. So it's not considered a secondary endpoint. It's a primary endpoint of the trial, but you first have to satisfy the non-inferiority.
But the reason you were doing this was to demonstrate non-inferiority based on the requirement of the FDA?
So I think you can argue that point. I mean, I think if you talk to the statisticians, they will respond. We did this trial for two reasons. First is to satisfy the FDA for non-inferiority, and then using the statistical methods in terms of saving the p-value, we can then move to superiority. So it's I'm not a statistician, but it's considered in the field a legitimate. It's not, oh, by the way, we just happen to look at as a secondary outcome. So it's an important point because when
the trials were not negative.
Yeah, right. So this is an important point. When we say negative, we clinical trialists think of a neutral study. But if your goal was to show non-inferiority, you could say it was a positive trial. But I think these are semantics. It was the effect on the primary outcome was neutral. Or non-inferior and then superior.
Thank you.
There was a question here. Yes.
In these trials, they look for inflammatory markers like CRP.
So we did an IRIS, and we showed a reduction in CRP. And actually, I didn't show you, but we did a mediation analysis, and CRP contributed a little bit to pioglitazone's effect. Interestingly, the effect on insulin resistance, which is what we titled the trial, didn't seem to mediate the benefits, but CRP did. We did not measure CRP in EMPA-REG. I'm not sure about the other trials. In the middle here? Yeah.
Your thoughts on when looking at the outcomes, right? Specifically, stroke. Common stroke is only mechanistic, right? And small as the parts of the boom, we know what we're talking about.
Right.
And just like something
Right. So we have an IRIS, and we see benefits in, we did not see a benefit in hemorrhagic stroke, mainly in ischemic stroke. And most of the strokes that occur in these trials are ischemic strokes. But you're right, there's lacunes, there's atherothrombotic, there's embolic. It is a bit of a wastebasket, isn't it? There's lots of controversies about, is MACE the proper endpoint? Cardiologists are now saying there should be 4-point MACE, and not the traditional 4-point MACE, which is ACS or need for revascularization, but heart failure. For heart failure, hospitalization, according to some, should be thrown into the now it's not necessarily always atherosclerosis mediated, but you're absolutely right about stroke. It is a bit of a wastebasket. Right?
Are some of these large studies, or are there other more focused, smaller studies trying to get at the physiologic effect and look at perfusion or cardiac reserve or anything that would explain that?
So those are obviously, there's lots of excitement when we published EMPA-REG, and there's a slew of trials now going on, small translational trials. I did not mention, but there are several large heart failure studies that are currently underway with the SGLT2 inhibitors. And interestingly, the studies are recruiting patients with and without diabetes. About 50% of the patients in these trials will not have diabetes. So the endocrinologists may lose this drug to the cardiologists because they may be effect. We won't know, obviously, for a few more years.
Actually, another question. After 8 or 10 really large trials, none of which have found inferiority, does the FDA change their mind on still requiring these?
So the question is whether we should continue to do these large CVOTs. So that's under discussion at the FDA as to whether, particularly, I can understand a new drug class because, I think the thought process that led to the guidance is the same, right? There's a new drug class. We have no idea what it does. Let's study it. But for the fifth DPP-4 inhibitor to have to go through this, there's lots of discussion. Obviously, industry does not want to do these because these are a couple of $100 million each. Now, I'm not crying for industry because if they sell these drugs, they make like sitagliptin, which is sold as Januvia, which has zero effect on cardiovascular. As I've demonstrated, I didn't show you the data, but the hazard ratio is 1.00, is a $6 billion drug per year. So, a couple $100 million on a cardiovascular outcome trial, if they hit, I think it pales in comparison to the potential profits there. But so I think that the cardiovascular outcome trials, at least for the near term, will continue to be performed. Yes.
So I'm curious about the outcomes, or really functional outcomes, in terms of those events that you're looking at. Could you track back to classic indices of risk, and how does that inform about how valuable those risk indicators are, clinical risk indicators, given that your functional outcome is the actual events? Did you learn something new about that? And the second thing is, are those risk factors different in a backdrop of diabetes than they are outside of the diabetic backdrop?
So I don't know the answer to the second question. If I understand the first question, is if you take your patients that are in these cardiovascular trials and you stratify them by risk for the outcomes, do you see heterogeneity, very similar to the question about racial differences or the genome? No. So we've looked at this. And so in EMPA-REG, you have to be very careful because everybody's at high risk because they've already had cardiovascular disease. One thing I forgot to mention is that in Canvas, about 30% of the patients were at high risk on the basis of risk factors. They did not have established CVD. Leader and Sustain as well. They had about 25 to 30% of their cohort having risk factors, so they were at higher risk, but not at super high risk. Interestingly, in those patients who got into Leader, Sustain, and Canvas, just because of risk factors, but not established CVD, they had zero benefit on MACE. I mean, the point estimates were 0.98. In Leader, it was actually higher than 1. It was 1.2. There doesn't seem to be a benefit, with the exception of, we didn't talk about the CKD progression, but these drugs, the SGLT2 inhibitors, inhibit the progression of CKD. In Canvas, in the primary prevention cohort, these patients with risk factors but no CVD, they still had the heart failure benefit and the benefit on CKD progression. So it's a lot to kind of to think about, right? But for MACE, I think patients with and without CVD are a bit different. Now, maybe if you treat them for 10 years, they'll see a benefit. They'll eventually start having events. But in EMPA-REG, we've looked at that specific question. So we use the TIMI risk score. So we take our patients and we divide them into 3 categories of risk based on the TIMI group, and no heterogeneity. So you had consistent benefit, but these were all patients with established cardiovascular disease.
Maybe time for one more question and answer.
Yes, one more.
So, to sum it up, do you think the Holy Grail is like looking for increasing insulin sensitivity?
Well, a few months ago I would have said yes, because I thought that pioglitazone was mediating its effects through insulin resistance. But we're just presenting next week at the ADA a poster that with this mediation analysis, and I was mortified to see that the measures of insulin resistance did not translate into the benefit, meaning it wasn't the patients who had the most insulin sensitivity from pioglitazone. So I think with pioglitazone is probably a direct effect on the vessel wall, probably mediated through PPAR. But I tease my colleagues saying that if we knew that, we would not have called it the IRIS study. Actually, we almost called it the ISIS study, which was a very good move. It's the insulin sensitivity intervention. I'm so glad. But it would have been I tease my colleagues saying we should have called it the PPAR intervention after stroke, but that has a terrible